First of all, thank you, Dr. Sinjab, Professor Sinjab, and Professor Tarek, and everybody else here on this meeting for inviting me here and for actually allowing me this opportunity to present. Sorry. I'm going to be talking about PDEK. First of all, let me apologize. I am down with a little bit of fever, so I am going to keep my video off. I'm going to talk to you about everything you wanted to know about PDEK. And let me say that I have no financial interest in the topic of presentation. So the PDEK graft, we know, includes not just the Descemet membrane and the endothelium, but also the pre-Descemet layer. And what this extra 15 microns of tissue does is it makes the graft much more robust and strong, and also it gives it certain special properties. The other special point about the PDEK graft is that you can have donor eyes which are really young. We've done used donor eyes as young as 1 year or even 9 months to create PDEK grafts, and that we know allows or gives you a huge reserve of endothelial cells which can be transplanted into the patient's eye. So the Duas layer is what creates or adds to the PDEK graft, and that's what separates or distinguishes it from the DMEK graft. The was described first by Harminder Dua, of course, in his landmark paper. And when we create the PDEK graft, what we are doing is basically creating the type 1 big bubble, which has all the three layers, as opposed to the DMEK graft, which is a type 2 big bubble, which has only two layers, that is the Descemet membrane and the endothelium. So this is how a DMEK graft looks like when you inject air into the conjugal rim. You can see that it always starts from one side and spreads across to the other side. And it's very flimsy and thin looking, as you can see here. And it's also a very large graft from end to end. On the other hand, the PDEK graft is very different. It starts from the center. It's very much like a dial big bubble. It starts from the center and it expands to the periphery. And there is a limit up to which you can enlarge it. My standard graft size is about 7.5 to 8 mm, actually 8 mm, I would say. And sometimes I get as large as 8.5 to 9 mm and sometimes about 7.5 mm. But that's because it also varies a little bit based on the donor white to white. That is my impression about the PDEK graft. I'm trying to do a study on that. But just like the PDEK, the big bubble, the Anwar's big bubble, this also starts from the center and goes to the periphery. Now, the advantages, as I already said, you can transfer a larger quantum of cells. You have, therefore, the effect of surgical loss is less. You have better corneal clarity, obviously, because you're using such young donors, and decreased chances of primary graft failure as well as longer graft survival. As I said, it's a very resilient graft. You can see this is a PDEK graft, and you can see it does not tear. I'm actually pulling it to both sides, and it's not tearing, unlike the DMEK graft, which is very fragile and easily rips. The other advantage is that it's got an easy learning curve. Because of this robust nature of the graft, you really have much more ease in tissue handling. It's very similar to a DZEC graft, and so it combines the advantages of both PDEK and DZEC, DMEK and DZEC, in that you get very thin grafts which have their own advantages, as well as you also have very easy surgery. So the advantages of PDEK graft, as I said, are young donor tissue and strong grafts. And what did I do, or how did I overcome problems doing PDEK? I used a few techniques which I've described. That is the e-PDEK technique, the air pump assisted PDEK, post-descemetic scaffolding. We described the importance of a good iris IOL diaphragm and also iridodothermy, and I'll show you each of these successively. So e-PDEK or e-DMEK basically refers to endoilluminator assisted PDEK or DMEK, and we published this in the Journal of Cataract and Refractive Surgery and also Clinical Ophthalmology. And you can see this is what it does. We inject the graft in. Some of these corneas, are very edematous, especially in our countries. We do not get the Fuchs type of corneas where visibility is very good, but rather we get very poor visibility corneas. And you can see that when you switch off the microscope light and you operate with just the endoilluminator light, shining light from the side, you can see it's a much better visibility. So as opposed to this, where you cannot make anything out which side the graft is, consider this, where you can easily see the graft is facing up, and without even entering the antechamber, you're able to confirm orientation of the graft. And so you can really have very good visibility even in very bad corneas. Here's another example of the e-PDEK technique, where even by loading, you can, while it's still lying in the storage medium, you can confirm the side and load it the right way. Now, the other technique I use is the air pump assisted PDEK technique. And what this does is basically for it uses air that is being supplied through an artificial anterior chamber maintainer. So you'll see this is a case where we are doing cataract surgery with IOL implantation, and this is a case of a failed OPK graft. So there are multiple factors which increase the which make the surgery more complex. One, you're combining it with another surgery, and second, it's already a failed graft. So obviously the curvature differences that exist can cause problems. But because it's PDEK, we are very comfortable now. So doing this kind of surgery, you can see that I've done the IA. Let's just skip all of this. We put the intraocular lens in. And now we are using the air pump assisted technique. Now you can see this is artificial end chamber and it's just got air going in. And you can see the decimeter excess being done with a reverse Sinskey hook, and look at the margins of the decimeter excess, very clearly seen, as opposed to doing it under fluid, or as opposed to doing it with just an air bubble which is not connected to an air pump, because the air bubble can keep getting coming out of the anterior chamber, especially when you go in with instruments. You can see here I'm also doing a PI with under air, and that prevents the bleeding from the peripheral iridectomy. So you can do a PI on table instead of doing it the previous day with a YAG laser. And here you've seen that I've injected the graft. We've opened up the graft, and that's another important difference that epipestic PDEK allows you. You don't have to operate for for a very, very long time trying to make sure that your graft is perfectly centered before you float it up, or trying to make sure that it is fully unfolded before you float it up, because these are all difficult steps, and these are what prevent the standard usual corneal surgeon from adopting PDEK. But you can see here, just like the Descemet graft, the graft was open and then we just pulled it into a more centered position. Small edge folds can easily be opened up, again using the air pump that is continuously infusing air into the anterior chamber. And you can stretch out the air pump, make sure that the graft edges are completely unfolded, make sure that it is in the final position that you want it to be, and thereby you can get good outcomes. So here's another video where I'll show you how the graft can be unfolded. Here you can see me unfolding and floating up the graft. You'll see soon there's a peripheral edge fold, which I'm not going to be too much bothered about, because I'll be able to look at that peripheral edge fold. I will just unfold this using the air pump assisted PDEK technique, and that gives me a very, very good well placed graft. So here's another video. This is a patient who had a peripheral iridectomy being done. Now in this case, I'm using just saline. I'm measuring the diameter of the graft that I need to put in. And generally, sometimes I just use the trephine. I create the big bubble and then use the trephine to match the diameter that I desire. Trephine to punch the PDEK graft. And you can also always mark the PDEK graft. So here you can see that I notice that there's no intraocular lens there. So many of the details may not be visible on slit lamp. And so now we have to shift our strategy and change to a glued intraocular lens. And many times we do advise the patient that on table there will be certain decisions taken which will change the strategy of operating and the surgeries that are required. Now what I'm doing is I've put in iris hooks to kind of enlarge the pupil a bit and do a vitrectomy. We see the intraocular lens has actually fallen down. So that's the reason it's also important to check what is happening in the posterior chamber and not just assume. But we can see the single piece acrylic IOL that's there. It's actually floating in the posterior, mid to posterior vitreous. And what I do is do a vitrectomy around it. Sorry. And then grab it with a forceps and bring it out into the anterior chamber, cut it, and then explant it. So both the pieces are explanted, and then we go ahead and do a glued intraocular lens, bringing both the haptics out, and then tuck it into the intrascleral shadow tunnels. Now the pupil has become a little irregular because of the iris hooks that were used. And so we're going to do a pupiloplasty just to make the pupil round again. And once the pupil is made round, we go ahead and do the PDEK and put in the graft, and the patient you can see looks much better. Now you can see that there's a little pocket of fluid there, and you saw that just now that the pocket of fluid can be released using the air pump and just like you do in Descemet. But this was the only time this ever happened to me. You can just also massage the pocket of fluid to the sides with the air pump, because that will also allow you to push the fluid away. If that doesn't work, you could possibly put a transcorneal incision to drain that fluid. But that really is quite rare, as I said, and it was the only time that it's happened to me in the huge number of cases that I've done. Here's another tough case that I had done, and just to let you know, you should never take any case for granted. I did the PI. I hope this is not the same case that I'm showing you. One second. Yeah, I think, sorry, this is the same case that's come up. So air pump assisted PDEK allows you to perform PDEK and certain steps also in DMEC. So if you're finding DMEC difficult, you could also utilize it for doing a few DMEC techniques. It utilizes pressurized air infusion. It acts as a third hand within the anterior chamber, allows easier graft centration, unwrinkling, and removal of peripheral inward edge folds. It tampons any bleeding in the antechamber, which is a huge help because you don't get this fibrinous atmosphere in the AC, and it also maintains the AC during various intracameral maneuvers. Assisted PDEK. So here's the air pump in hemorrhage. Here's a patient who's got a hemorrhage, and what we do here is put on the air pump. You can see that's the trocar antechamber maintenance that's got the air pump going, and we continue with surgery. We go ahead and strip the Descemet's membrane, and the air prevents extra bleeding, as also tamponates the bleeding and makes the bleeding stop. And once that's done, you can just wash the blood away and you get a clear anterior chamber, and you can proceed with the rest of your surgery. So here again, you've got the air pump. You can remove those blood clots using a microforceps, and the air pump actually holds the entire antechamber formed and not collapsing when you go to intracameral maneuver. So the AC can actually be reset in that it can be made to be a much better and quieter anterior chamber, which will of course give you a much better result. So it helps you in descemetorrhexis in a peripheral iridectomy, graft flotation, graft centration, graft edge unfolding, unwrinkling and uncreasing, graft adhesion. So that's another very important advantage that I found for the air pump. It allows the graft to adhere even before surgery is over. And that is a huge advantage for you because you're not worried about post-op detachments. It tampons intraocular bleeding from the PI, from synovitis, and prevents ooze of blood from corneal sections into the anterior chamber by preventing hypotony. It prevents antechamber depth fluctuations and acts as a third hand. Now, this is the reason why it's important to prevent blood in the anterior chamber. You can see this is a graft that was put, and there's a constricting ring of fibrin that's actually encircling the graft. And that's the reason, this is the reason why air pump can be so advantageous in preventing this blood from oozing and give you a quiet anterior chamber with the tamponating the bleeding and stopping the bleeding and controlling and making the antechamber much better. I already said how you can do descemetorrhexis. We've got the air pump, and you can see how the descemetorrhexis is being done in this post-PK failed graft. It's not just that you can do with the Reversinski, but you can also use a microforceps and go in and prevents basically AC shallowing while you're doing that. You can do PDEK with large iris defects. Here you can see a patient who's got an IOL capture, and there's a large iris defect over here in this area. So these are problems because the air bubble may not remain stable in the anterior chamber. So in this case, what I do is I've got the air pump going, and the advantage of the AC maintenance, you can use it for infusing saline or air, as the case may be, for different steps. So you're not changing anything. The same antechamber maintainer can be used for both. I'm cutting the synechiae between the iris and the anterior capsule just to make the iris free. And then we do pupiloplasty, make the pupil smaller. And now what we've done is we've kind of made the pupil smaller in this aspect, but we also have this large iris defect here. And my plan is to do an iridodialysis repair kind of procedure for this missing large sector iris defect. So what I do is create a groove, get fluid flowing through the antechamber maintainer this time, and use a trocar to kind of prevent the needles from engaging on the corneal lip, as Dr. Amar had found that this was a very easy procedure and prevents accidental capture of the corneal lip with the needle that's being used for iridodialysis repair, or even that may basically being used for iridodialysis repair. So once the iridodialysis repair has been done, you can see the iris has gone much more closer to the sulcus area, and it's not touching, of course, but I think this is much better than to get a good air tamponade than it was previously. And the pupil is a bit irregular, so for that we go ahead and do one more pupiloplasty, and then we go ahead and do a descemetorrhexis, do a IVT assisted vitrectomy, and put in the graft, load it in using an MIL injector, and we float it up, and the rest of the graft is unfolded. There's a special technique to do this where you start from one edge and the rest of the graft just automatically opens out. And once the graft is opened out, Here you see that this patient also had a large, extracapsular incision over here, which can be seen in the postoperative period also. This is day 1 postoperative period showing a clear cornea. And here is the patient at a more delayed post-op follow-up. Here's another example. As I said, sometimes you'll get intraoperative surprises. In this patient, I was doing the descemetorrhexis. I wanted to do a large descemetorrhexis because the eye was small, but unfortunately, when I tried to remove it with a microforceps, this is what happened. I got a large iridodiasis, pretty large actually. The entire iris ripped off from its attachment. So you do need to have a repertoire of techniques in your armamentarium so that you can handle any of this. Sometimes the patient may start from the beginning with such abnormalities, but sometimes it may also happen intraoperatively. And so what I do here is, again, do an iridodialysis repair by making a groove and then attaching the iris back using a double arm suture. And we've got the entire iris back there. We've got a round pupil. So that's looking pretty good. And then we go ahead and inject the PDEK graft and do an air pump assisted PDEK as well as a EPDEK. Here's, oh, I think that's the same video again, sorry. PDEK can be done even with Ahmed glaucoma valves. This is a valve that was placed in the anterior chamber. I personally never like to place valves in the anterior chamber because I think all corneal surgeons will agree that with time they do inevitably lead to corneal damage. So I have reshifted or repositioned it into the posterior chamber behind the iris, but in front of the intraocular lens. And we've got the graft in. And since I'm using air pump assisted PDEK, the graft actually attaches even before the surgery is over. And that's a big advantage because even in these AGV cases, you do not have postoperative graft attachment. Here's another case with Ahmed glaucoma valve. In this case, the previous case was with an Ahmed glaucoma valve already in place where we just did tube repositioning. Here we have a case where the AGV is going to be fixed. Sorry, I think that part of the surgery is here. So yeah, we fixed an AGV. I do my standard technique, and if anybody is interested in that, it's there on YouTube, on my YouTube channel. Prevents all kinds of problems like tube erosion and things like that. And once the AGV is done, we keep the tube away. We don't insert the tube now, and we go ahead and create the graft. And this is how you can also, if you want, mark the graft. Maybe I'll show you a better video for marking the graft for those who are interested. We don't do it in every case because we have the EPDEK technique, but just to show that it's possible, I have used this technique. So we've injected the graft into the anterior chamber. The PDEK is already here. Now, if you remember, I cut the graft here with a scissor, partly with a trephine and partly with a scissor. And when that happens, sometimes you can have a bit of stroma on one side. So there's this graft which also has some stroma, and I'm a little worried whether that area will detach just because it's more heavier, sort of to say. So I'm taking sutures through the graft, and that's again another advantage of the PDEK graft. You can actually transgraft sutures, unlike the Descemet graft where you'd be very worried about the graft dripping. And the air pump again helps you in this technique because the air pump is giving you pressurized air infusion, giving that third hand support from inferiorly to the graft, which allows you to take these sutures and make sure that the graft is not detached from any place where you're particularly worried that it may detach. We then finally go and put the tube under the iris and over the lens, and then that's the end of surgery. And this is a patient about, I think, 1 week to 10 days post-op. It also allows host descemetic scaffolding, and this is another one of my techniques which I used for PDEKs and DMEX and the tough cases. Basically, it won the best paper award in the ASCRS, and this is how we do it. Generally, we do the descemetorrhexis larger than the size of the graft, so that the graft doesn't overlap, or so that the host descemet doesn't overlap the descemet's membrane and cause a detachment in that area. But if you notice in this case, I'm doing a small descemetorrhexis. This is going to be smaller than the size of the graft. Again, notice the air pump giving you exquisite control in getting the size of the descemetorrhexis correct. The EPDEK technique allowing you very clear visibility of the graft orientation. We open up the graft. We don't worry too much about that one edge fold, which also decreases manipulation within the antechamber and possibly will decrease cell loss from repeated rubbing over the iris. We center the the graft, and now if you notice, I'm using that host descemets to kind of capture the graft in place. So the host descemet which was lying above the graft is now pulled out or teased out to lie in a position that is below the graft, so that it is actually supporting the graft from below. And again, this is possible because of the host air pump assisted PDEK technique. So this is what I call as host descemetic scaffolding, where the host descemet membrane is made, descemetorrhexis is made smaller than the graft, and then it's used as a scaffold to kind of support the graft from within. Sometimes I also do wound scaffolding where if the graft is very large, we place part of the graft into the wound, and you can see here that's what we've done here, and the cornea looks pretty good. And that there, of course, you cannot have it in a way that it comes out of the wound. It should be only 50% within the wound and not more than that. And we have mentioned all these techniques in the JCRS article and all the precautions to be taken when you're doing these techniques. Here's a patient where I do phakic PDEK to show you that all of these are possible. This was a young girl, so I did not want to do remove her cataract, her phakic lens, her crystalline lens, which was clear. I've done a PI, and then I've got fluid going in this case, and I've marked the size of my descemetorhexis, and I removed the Descemet's membrane. Once that's done, we load the graft and open the graft up. So you can see that the majority of the graft has been opened up. It's only small peripheral edge folds that are corrected with the epam-assisted technique. Also, graft centration can be easily corrected with the epam-assisted technique. Once we do that, we do a little bit of host descemetic scaffolding because the host descemet membrane was a little smaller. But also look at this. If you want, you can also tear away the host descemet membrane, which is lying under the graft, because the air pump is going. You can see inferiorly the air pump going. So you can actually strip the Descemet's membrane away because the antechamber is well maintained, and you can do all these maneuvers without touching the graft, without damaging the graft, and having adequate distance between your instrument and the graft. So again, you can see me stripping that Descemet's membrane away so that it's not lying under the graft. Now we've put an 80% air bubble since she's phakic, and this is the first post-operative day appearance of the patient. We can do it for vitrectomized eyes, as I said, PDEK. Now, these are all situations where you would not consider doing a DMEK because these are areas where you might get a DMEK detachment, and you would possibly consider doing a DZEK in these cases. But we've completely stopped doing DZEK and DMEK. We do only PDEK as our only endothelial keratoplasty procedure in all cases, irrespective of the indication. So here you can see that this we've already done a gluteal. We've placed the IOL in position. We are using the PDEK technique to identify the side, and then we open up the graft. And here is the first week post-operative appearance of the patient. Dilated and fixed iris can be used, can be done. PDEK, we can do it with an NIRD IOL where there's essentially no iris at all. No, and it's a monocameral eye, basically not iris at all, but it's a monocameral eye. So here you can see an NIRD IOL. You have the danger of the PDEK graft slipping through in the gap between the edges of the optic of the NIRD IOL. So what we do here is NIDL was a little subluxated. I've corrected that as a first step, and then we load the graft. And because the air pump is there, we can very quickly trap the PDEK graft between the host stroma and we can basically very quickly trap the PDEK graft against the host stroma and therefore prevent it from falling into the vitreous. I think this is an EPDEK technique, so I don't need to show this. Is a video that I've already shown. I just want to show you some other tough cases. Retrocorneal membranes, extensive iris synechiae. This is the patient at presentation. Measure kind of the size of the graft that I want to put. We've created a bubble, put in the air pump. You can see it's really a bad cornea, and the retrocorneal membrane has been pushed back against the iris while inserting the antechamber maintainer. We dissect that membrane off. This iris was actually lying against the cornea, stuck against the iris cornea. So we're using a combination of vitrectomy, microforceps, peeling, a lot of post-Parsonina vitrectomy steps that vitreoretinal surgeons use. You can see membrane peeling and all that we use to remove all those membranes from the iris. And once the iris is more mobile to say and is amenable to a pupilloplasty, we do a pupilloplasty. We've got fluid running through the antechamber maintainer at that time, and then we go ahead and open the graft. And this is the patient's post-operative appearance. You can see it's a clear cornea, very different from what we started out with, which was like this. And we've reached a position where we are like that, which is pretty good considering everything the patient had. Here's another case. This was a large therapeutic PK, which was done for a corneal ulcer. And again, you can see the cornea is really bad to start out with. A lot of iris membranes. Again, we opt to do a PDEK in this case. We need to dissect those iris membranes off the iris. And for this, I use a needle. Again, using some techniques of vitreoretinal surgeons, we use the needle to kind of peel the iris membrane off the surface of the iris. And once it's peeled off, we can use scissors to cut it or just pull it free. And now we saw that when we did that, the pupil was completely closed. So now we've gone ahead and made a pupil there, created a pupil there, some bleeding, but you can't help it. Of course, you're handling the iris, so that will be there. So that's you've got the air pump, sorry, the fluid going in there, which washes the blood out. You could also use air pump once the iris manipulations are over, but iris manipulations would be a little more difficult with the air pump. So here we see that there's no lens, and so now we're going to do a glued intraocular lens. And many times you don't know the history of these patients because they've got operated somewhere else and then they come to you. We put in a glued intraocular lens. You can see the haptics are already out. Now we're doing a pupilloplasty, making that pupil rounder because you want to get a good air support. Check our air support by putting in an air bubble. So that's a stable air support to close the flaps of the glued IOL, and use the air pump assisted technique to open the graft up. And this is the first postoperative day appearance of the patient. And you can see also the later delayed postoperative appearance of the patient, where we started out from here and we came here where the patient had extremely good vision. So host descemetic scaffolding, I think I already explained. I'm not going to go into it again, but this is what it looks like. We've got the PDEK graph there, which is supported. So basically, no, this is the how a conventional DMEC would look, where you have a graft and then you have a gap and then you have the host descemet membrane. But in host descemetic scaffolding, this is what you see. We have a PDEK graft and that is supported from inferior by the host descemet membrane. These are all examples of host descemetic scaffolding and wound scaffolding. And we can see that the ASOC is actually confirming the scaffolding. Stable iris IOL diaphragm, we had described this way back in the Journal of Refractive Surgery, that it's really important to have a good iris IOL diaphragm, which covers IOL optic all around to get bicamerality. So that's a very important thing, and you need to know iris repair techniques for that. This is a new technique which we've submitted now, and it's almost accepted for publication. It's just in the revision stage. Hydrodiathermy for floppy iris. So sometimes you get this floppy iris, which causes air to go posteriorly. And for this, if you look here, the air is migrating behind the pupil. We've got the air pump, and the air has gone behind the pupil, and the superior iris is being pushed against the cornea. We've got iridocorneal touch superiorly. So what do you do in this situation? Whatever you do, even if you inject an air bubble, the same thing is happening, and that's because of the floppiness of the superior iris. We try to stroke to reposition the iris, but that's really not working because again, you can see the floppy iris above. So what I do in this stage, in this case, is use the endodiathermy to flatten the iris. So watch carefully that floppy iris immediately becomes flat. So you can actually see it flattening out, and all the floppiness is gone because the iridodiathermy actually shrinks the iris a little bit in that area and removes the floppiness. And now you get a nice stable iris IOL diaphragm, which is going to give you much better support for the corneal graft than what you had previously. So this is a technique that I call as iridodiathermy for better bubble dynamics in endothelial keratoplasty, whether it's a DMEC or a PDEK. You can also do iridodiathermy, of course, for open sky PKs in a similar way. Just do an iridodiathermy and the floppy iris can become less floppy even there, and you can avoid the post-operative peripheral synechia that would otherwise form. When required, you always combine it, of course, with the suture iridoplasty. The iridodiathermy alone is not the answer. So do a suture iridoplasty. Now, if you see a bunched up iris over there post-suture iridoplasty, you can do a little bit of iridodiathermy just to flatten the iris out. So again, look here. This is a bunched up iris, and we've done iridodiathermy here, and the iris has really become flatter. So maybe here. Okay, this video has some problem playing, but if you look here, this is initially, and this is after iridodiathermy, and it's a flat iris now. Here are other examples of iridodiathermy for flattening the iris. So to sum up, PDEK allows you to use younger donors, easy in preparing the graft with no special instruments. We have now pre-prepared grafts for those who want to get free of the hassle of having to prepare the graft themselves and the possibility of losing tissue. Just like in DMEC, you have pre-prepared, pre-stamped grafts available from a few eye banks. It is thinner than ultra-thin DSEC also, so it's got big advantages: increased resistance to tearing of the graft. It's very easily adaptable to the FM assisted PDEK, easier centration, graftage, unfolding, easier learning curve, and improvement in CDV, decrease in central corneal thickness, decrease in graft thickness from the post-operative day one itself, unlike DSEC. So what are the presumed disadvantages and how to overcome them? This is what people ask us. Size is smaller than a DMEC graft. Generally, I obtain between 7.5 to 9 mm, and the standard is about 8 mm. So that's about the same as an OPK and very close to that of a DMEC. So we get good results with that. The other option is I got a type 2 bubble, in which case, if you want, you can continue as a DMEC. But as I said, you already have prepared grafts now available. PDEK, you need to open a vitrectomy set, which can lead to extra costs. That's another disadvantage that people say. But now you get standalone endo illuminators from DORC, which is something that you can buy. I have no financial interest. Infusion pressure is kept at 30 millimeters mercury and increased whenever there's a leakage from the wound. So if in case the question is about how much infusion pressure you keep the air pump at. A young graft may curl more, air pump, so that's another disadvantage which people state. But remember that the air pump assisted PDEK makes it easy. It's available in newer phaco machines. It's also available with the fluid air exchange system present in posterior vitrectomy systems. You can also use air pump via a millipore filter. You have better cell count and presumably healthier cells in a young graft. So I think with that, sorry, I will come to the maybe just this one video which shows a very large graft size that is possible in, let's just skip this part. Even in PDEX, we can see the graft is literally going from end to end. So you don't want really graft sizes larger than that. You get extremely clear corneas and the clarity keeps improving with time. For those who are interested, I've written a book on mastering endothelial keratoplasty, which has got a volume 1 and a volume 2. It's available from Springer. And with that, I'll come to the end of my presentation. Thank you so much.
Thank you very much, Susan. Actually, first of all, I would like to thank you for your time and for being very generous. And this is, of course, the habit of generous scientists like you, who take care about people and even on the account of their comfort. So please.
Hello.
Or an alternative to, hello?
Sorry, I lost audio for a second. Did you ask me any question?
Yeah, there is a question from one of the audience.
Okay.
Okay. My question is, what is air pump? Is it like air bubble or an alternative to anterior chamber maintainer?
So air pump is basically an anterior chamber maintainer, which is fixed at the limbus. And you can use this for infusing either saline or air, as the case may be. If you're using it to infuse saline, you could use it just from a normal, a saline bottle or a BSS bottle. Or if you're using air, you could fix it to one of the newer phaco machines or preferably to the vitrectomy fluid air exchange systems, because that allows you to actually titrate it even up to millimeters mercury. So generally we put it at 30 millimeters mercury, as I said, but you could increase because there's constant leakage from the incisions. Remember that. So 30 millimeters mercury at the in the machine does not indicate 30 inside the eye. So you could increase it and just feel the cornea to get an assessment of how much the intraocular pressure is.
Yeah, it's very clear. Now, in general, let's say that the PDEK can be an alternative to the DMEC and DSEC in general, in every case.
Oh yes, that's as I said, we've completely stopped doing DSEC and DMEC. We don't do it at all. All cases undergo only either PDEK, or if there's a corneal scar that is unlikely to improve, we do an OPK. So those are the only two surgeries we do for endothelial diseases.
Yeah, because I know that there are some restrictions for the DMEC, like vitrectomized eyes or aphakia or iridia, but it seems that the PDEK came with a good solution for such cases. So is it that easy to do it in such critical situations? We have seen, of course, wonderful videos that you presented, but I mean, as a beginner, is it easy to learn the learning curve?
I understand your question. The tough cases, since my topic was tough cases, the tough cases are always, of course, more difficult. So I would not recommend a learning surgeon to go straight for this. Learn the techniques, the EPDEC technique, the air pump assisted PDEC technique, the importance of iris, IOL, diaphragm. Learn all of these in simple cases, and then you can transition on to all the more tougher cases. But however, if you compare, let's say you are a surgeon who's at a certain level of training, and you see a tough case and you think, should I do a DMEK in this or a PDEK in this? The PDEK would be easier for you, because the DMEK will have more problems in intraoperative opening, centering, making sure the graft edges are fully unfolded, making sure that you don't get any post-operative detachment. PDEK really solves many of those problems, because the air pump assisted technique is a huge help. It's a third hand. You could use it a little bit for the DMEK also, but the graft centration you wouldn't be able to do even with the air pump assisted technique for DMEK, because the DMEK graft would tear. There's no way you can just pull a DMEK graft across the anterior chamber like I showed you in some of the videos, because it would just rip. Whereas the PDEK graft can be easily pulled. You float it up, even if it's decentered, and you pull it into position, and you'll see that the PDEK graft easily moves. This does not mean that I'm recommending rough manipulations, because of course, every time you do rough manipulations, you will lose endothelial loss. So you have to hold the PDEK graft only at the very peripheral edge. That's important. And there's a way to unfold the peripheral edge folds, where you start at one edge and then you just kind of give a tug, and the large majority of the graft of the fold opens up on its own. So you may have to touch in 2 or 3 places, and that's it.
Fantastic. That's great. And thank you for sharing the book, the two volumes of the book. So, of course, we would recommend everyone to read the books before starting such procedures. Do you have videos in the book as well? Is it connected to videos?
Yes. It's a video textbook, actually. So there's beautiful videos which are there in the book. But the book, however, is for all types of endothelial keratoplasty, Descemet, DMEK, and PDEK. So if anyone's interested in all the 3 endothelial keratoplasties, I would recommend you can buy the volume 1 and the volume 2. Volume 1 is for more straightforward cases, whereas volume 2 is for the tough cases. So depending on your stage of learning, you could opt for one or both volumes.
Fantastic. Another question, Susan. Do you conduct any wet labs or hands-on procedures like PDEK courses in your institution?
Oh, yes, we do. We have a wet lab course, as well as we have hands-on course for PDEK, and that is something that we've been doing along with our FACO training and stuff. So that is something that if you're interested in, you could email me or Mr. Kumar Guru. I think many people might have both our emails. I do not have any financial interest in the training. I'd like to say that.
Thank you very much. I will be the first student then.
Thank you, Dr. Tarek. I mean, Dr. Sinjab, but Professor Sinjab, but I'm sure with your golden hands, you do not need any of that.
Thank you very much. Okay, now some other questions. What are indications for PDEK? I think you mentioned that already. Can we do Descemet with excimer laser?
I don't think so. I don't think it makes any sense doing it, because you would not be able to control it. You have to do a descemetorexis on the internal aspect. So you would literally have to go through. If you're talking about descemetorexis kind of cutting the graft edges alone, it would have to be done with a femtosecond and cut the graft edges in a circular pattern and then strip it. But it's really not required. I think it's an unnecessary use of technology. Excimer laser is just for ablation. It would not be of any help in any of these situations.
Very good. Another question, how can we get the book? I think through Amazon.
Yeah, you can do through Amazon or through Springer, whichever, either way.
Springer as well. Yes, great. So we came to the end of the session, and as usual, we learned a lot from you, Susan. Personally, I learned a lot of you, and thank you very much actually for devoting this time despite your health issues. So please get well soon, and God bless you. Thank you, Susan.
Thank you so much, Professor Sinjab. It's an honor to be on your academy. Thanks a lot. Bye-bye.
Thank you. And thanks for the audience. And later I will message you regarding the recording. Thank you, Susan.
Okay. Thank you. Thanks a lot.
Goodbye.
Goodbye.
Goodbye.